We should be simultaneously broadcasting on Facebook Live as well as Zoom. So with us today is NorthBay vascular surgeon, Melissa Loja, and she's going to be talking to us today about aortic aneurysm. Take it away, Dr. Loja.
Thank you. My name is Dr. Loja. I'm a vascular surgeon here at NorthBay, and today we're going to chat about abdominal aortic aneurysms. The abdominal aorta is the major artery that brings blood from the heart down to the body. This normally is a single 2 centimeter or 0.8 inches tube that brings blood down from the heart through the thoracic, through the chest, the thoracic aorta, and then into the abdomen. And in this portion, we call this the abdominal aorta. If that artery is too big, so in this case, in the abdominal aorta, if it goes more than 3 centimeters, we consider this to be aneurysmal. What is an aneurysm? So a normal artery is built with muscle in the middle of the layers of the artery. So the picture on your left is a cross section through an artery, and you can see there's a thick elastic muscle layer. And what this does is allows the artery to expand and contract with every beat of the heart. When that muscle lining gets weak, it no longer expands and contracts as it normally would, but instead continues to expand and grows in size. So you can see in the point B in the middle screen, that cross section of the artery, it is wider with less muscle layer, it is weakened. And as you can see on the animation on the right of the screen, as it weakens, it can grow. And it can grow so much that it can actually pop at a certain size, which is why we worry about them. Abdominal aortic aneurysms are actually relatively common. 200,000 people are diagnosed each year with this. It occurs in about 13% of men and about 6% of women over the age of 65. And actually ends up being the 10th leading cause of death in men over 55. This altogether leads to about 15,000 deaths annually in the United States. Unfortunately, there's often no symptoms of having an abdominal aortic aneurysm. In 60% of people, we find these on routine surveillance screenings or on other CT scans or things that have been ordered for other reasons. We just incidentally find them. And most often our patients are asymptomatic. Other symptoms include sudden severe abdominal pain or tenderness deep in the abdomen, and this can indicate an abdominal aortic aneurysm. The aneurysm, because it's wider, can build up clot within it. And so one other sign of an abdominal aortic aneurysm is if that clot goes down to the feet. That can cause cold toes, blue toes, or wounds on the feet. And so if we have these, this is one of the things that we look for if that is your symptom when you come in. Who is at risk for abdominal aortic aneurysms? So on the left of your screen is things that we can't control, and on the right of the screen is things we can control. So it is more frequent the older you get. It is more frequent in men, and it is particularly more frequent if your first degree relative, your parents, have had an abdominal aortic aneurysm. It's present if you have atherosclerosis, so this can be heart disease or peripheral disease, so leg artery blockages. It's common if you've had something like an aortic dissection or if you have a connective tissue disorder. On the right, the modifiable, the changeable risk factors include high cholesterol, high blood pressure, and then smoking is a very large risk factor for development of an aneurysm. If one of your parents have had an abdominal aortic aneurysm, you are 12 times more likely to develop a AAA in your lifetime. Of all the patients that come across and become treated for abdominal aortic aneurysms, almost a quarter of them will have had some sort of family history associated with it. And if you're an active smoker, an abdominal aortic aneurysm is 7 times more likely Active smoking also leads that aneurysm to get bigger and bigger with time, and also is a higher risk that that aneurysm will pop. The length of smoking is actually more important than the number of cigarettes. And so it's not, unfortunately for aneurysms, it's not enough to cut back the number of cigarettes. You have to quit to decrease your risk. You have to stop smoking altogether. As I said earlier, most aneurysms cause no symptoms at all. And physical exam is difficult to find the aneurysm because it's all the way at the back of the abdomen. So we typically only find them on physical exam when the aneurysm is very large or in very thin patients. So how do we find them? We recommend doing a screening ultrasound. So the current recommendations differ based on which organization you ask. We typically recommend a one-time ultrasound screening at the age of 65. And this is in people, anyone who has ever smoked, male or female. Medicare guidelines are a little bit different, and they recommend mostly male screening at age 65 for smokers. But the SVS guidelines, which is our national organization for vascular surgery, is in favor of screening women who have smoked at age 65. And then anyone with a first degree relative with an aneurysm, so a parent with an aneurysm, should be screened with an ultrasound to have if they have an aneurysm. Most of the aneurysms develop or are found between 60 and 70 years old. And if at age 70, we do an ultrasound and we find your aorta is no bigger than 2.5 centimeters, then it is extremely unlikely you will ever eventually end up developing an aneurysm. And that's why we do a one-time screening. The natural history of an aneurysm, once you have it, is typically that it expands and expands, and at some point it ruptures. A rupture is a fatal process in 90% of people. We have some therapies that we're able to save you if you come in with an abdominal aortic aneurysm rupture, but it's much more difficult when you're actively bleeding like that. So we try and repair these before they ever get big enough to pop. Many, though, do not change in size. So we put people on protocols where we watch aneurysms over time and see how they develop and how they're growing. And the larger the aneurysm is, the faster that it will grow. And on the right, this is a CT reconstruction of what we're looking at when we do these ultrasounds and CT scans to follow. So at what size do we fix these? So in women, we fix at a smaller size. And this is because women, even though they're less likely to develop an aneurysm, that aneurysm is more likely to pop at a smaller size. So we recommend treating that at a smaller size at 5 centimeters. In men, it's less likely to rupture. So we go up to 5.5 centimeters as our threshold to fix these. We also look at how fast it grows. We expect it not to get bigger than 0.5 centimeter every 6 months. So on the screening protocols, we look at the speed of growth and then the overall size. And then we also fix it sooner if there's symptoms like severe abdominal pain or back pain. So why not fix these sooner? Why not fix these as soon as we find them? And the reason is, in this table here, you see that on the left is the risk of the aneurysm rupturing or popping. And on the right is the size. And what we find is small aneurysms tend to not pop. They tend to not rupture. But once they get to about 5 centimeters, now we're talking a real risk of rupture, so 11% per year. So we look at the overall risk of repairing it. And so if you look at the overall risk, endovascular and open together, you're looking at less than 5%. So at 4 centimeters, your risk of rupture is about 1% or even less. And so we consider it more risky to fix than to let you, keep living your life and watch it and watch how it develops and grows. So we offer repair once the threshold of fixing the aneurysm is greater than your risk of rupture. And that's how we came up with those numbers. So the most famous story of how we began to repair these is actually for Albert Einstein. So he had an aneurysm that was identified when Dr. Nissen was doing a procedure for a different problem, and he found this aneurysm. And he had one of the first earliest interesting treatments that was described, and he actually took cellophane wrap and wrapped it around the aneurysm. And it's postulated that Albert Einstein actually lived 5 additional years before his aneurysm ultimately ruptured and killed him. And thanks to the cellophane wrap. So that was where the first ideas were coming from, is externally holding the artery together with a cellophane wrap. Not that long later, so 1954, we developed newer techniques, and they tried all sorts of different materials, but ultimately in the 1950s, we ended up replacing that segment that was too wide with a piece of fabric. And so we'd sew that in, it's a tube of fabric, and that's the modern technique that we still use today. In the 90s, they developed a new way of doing this, and this is the cartoon on the furthest right. And this is called an endovascular repair because it's inside of the arteries. And what we do is we line the arteries with fabric from the inside. So that requires less mobilization. It's a smaller surgery, smaller puncture sites. And so really in the 1990s, after this first successful repair, it started this big revolution with all sorts of new fancy devices and new techniques that we use today. So the open repair is still an excellent choice for repairing an aneurysm in the right patient. So this is an incision on the belly, on the abdomen. You go down all the way to the back. You have to clamp the artery so it doesn't bleed. You cut open the walls of the aneurysm and you physically sew a new graft in. That graft is usually made of a polyester material, and it comes in a tube shape, and sometimes it has 2 little limbs on it, or sometimes it's just a tube shape, and that's sewn in on either side. This is a durable, time-tested repair. They last very well. They have a difficult hospital stay and a difficult recovery time, however. So most people are in the hospital for 4 to 10 days, and recovery time can be up to 3 months. So it's a durable, excellent repair, but upfront has a lot more time involved. Endovascular repair is only 2 small groin punctures and in some cases small incisions. This is done all in a fancy hybrid operating room. This is a picture similar to the state-of-the-art hybrid operating room we have here at NorthBay. Everything is done with X-ray imaging. The device goes on the inside of the artery, lines the artery on the inside, and that's how we put it in. So you can see in the animation on the left, the wire is guided up and the graft is deployed on the inside of the aneurysm. This reinforces the artery wall, excluding blood from going into that weakened wall of the aneurysm. This allows the blood to go from the aorta down into both legs without going into that aneurysm sac, as you can see in the bottom animation. This is a durable repair, but we do watch it more frequently, so they require more touch-ups. So because it's put on the inside of the artery, we have to make sure that those components stay in place and don't bend or kink because they can clot off. The major benefit of this is that most people get to go home the first day after surgery. There's a minimal recovery time. Some patients, it's up to 2 weeks. But most patients, they're home feeling better 1 to 3 days. So it certainly has an advantage, particularly up front. It has been as durable as some open repairs, but you do have to follow it more frequently to make sure it stays open and stays as durable as an open repair. So how do you reduce your risk? So overall, make sure that if you are in those risk factors, over 65 with a smoking history, for example, that you've had your screening ultrasound to see if you've had it. If you smoke, you should absolutely quit. Everyone has heard this before. And if you have a family history of aneurysm disease, you should absolutely talk to your doctor about getting a screening abdominal aortic ultrasound. Thank you very much for your time. Happy to take any questions.
Well, we have some questions in advance here, but just a reminder to those who are watching, You can type in your question as a comment. We'll see it and share it with the doctor. So you talked about what happens is that an aneurysm can burst. Tell us about, what is the problem? Why do we need to be really aware of this and not allow that to happen?
Yeah, so if the aneurysm were to burst, then all of your blood pressure is going into your abdomen. So only about 50% of patients will even make it to a hospital. And even if you make it to the hospital, then we have to find a way to repair that artery while it's actively bleeding. And so even with the best technology, endovascular and open techniques, there's still probably about 50% of those people who actually end up surviving that operation. And then just from a technical standpoint, it's harder. So that you have a lot of time when you fix them ahead of time. You have a lot of time to plan out what the difficulties will be, how to make sure that you're not causing any harm. And you don't have that time when you're doing it emergently. And so the complications, if you survive it, are much higher. So there's been a lot of studies on this. One of the more recent ones said there was a 80 to 90% chance that you would not make it through an abdominal aortic rupture. So better to fix in advance.
Yes. Are there general symptoms that you can look for that would indicate you have an aortic aneurysm? When we talk about heart attack, we talk about chest pain and arm pain and so forth. Are there symptoms that should prompt you to say this could be an aortic aneurysm? I need to go get this checked out.
Unfortunately, not really. The main symptom we talk about is abdominal pain, and that pain can actually radiate into the back or be perceived as back pain. But it's difficult because lots of things cause abdominal pain and lots of things cause back pain. And so it's not a very specific symptom to describe to someone. So for the most part, we look for risk factors and we rely on our screening. But if someone has severe onset abdominal pain, then that's something that should prompt them to go to the emergency room and get a CT scan. And that absolutely will tell if there's a abdominal aortic aneurysm or if it's ruptured or something like that.
Betsy is asking a question. I think there's some typos here, but it says, what causes an aortic aneurysm on the artery next to the heart? Maybe that's what she meant.
Yeah, so the weakening of the walls is what causes an aneurysm. So most of the time that's caused by cholesterol and lots of blood pressure going through that area. And it degrades the integrity of that muscle. And so it weakens out and that artery starts to expand. In some people, it's actually a more genetic component that the walls are just not as strong. Most people know that they have these disorders. So it's like Marfan syndrome or Ehlers-Danlos syndrome that can lead to having more aneurysms. But most of the time it's inflammation. It's inflamed, angry arterial walls that end up expanding over time. And most of the things that cause that inflammation are the irritants from smoking, hypertension, high cholesterol gets into the walls, irritates it, and makes it expand a little more quickly.
You talked about the size of an aneurysm when you'll decide to do surgery or surgeries needed. Is it possible to have an aortic aneurysm that's smaller than that and just maintain it over a long period of time and it won't ever get bigger?
Absolutely. So I said earlier, it grows faster the larger it is. So a small aneurysm, like a 3.5 centimeter aneurysm, there are lots of patients who have aneurysm over time, same exact size, and it never actually grows. It can stay that size forever. The smaller it is, the less frequently we check it because it's less likely to grow. The bigger it is, the more frequently we check it. But there are plenty of patients who stay below that threshold for fixing and just stay at that size with the aneurysm and we just watch it.
So you talked about watching it and checking it. What specific tests are you doing to identify one and watch it over time?
Yeah, so for most people, this is a simple ultrasound. So that gives us really good data on what the size of the aorta is and any of the characteristics of how the shape of the artery is. We can also do CT scans. These usually require contrast, so that can not be ideal for certain patients, but with the screening, we rely very heavily on ultrasound because it gives us the data we need.
And how often will you check on an aneurysm once it's diagnosed?
Yeah, so that's a great question. So every surgeon is a bit different, but in general, it's based on the sizes. So the bigger it is, the more frequently it's checked. So for 4-centimeter aneurysms, we typically check every 6 months. For smaller aneurysms, for example, in the 2 to 3 range, you're not considered an aneurysm, but it's bigger than that normal threshold. So we'll check those every 10 years. So it's different based on the size, but typically it's either yearly or every 6 months.
You talked about certain risk factors. Is hereditary? Can these be hereditary?
Absolutely. So very, very strong risk factors for hereditary aneurysms in the abdominal aorta.
And are they associated with other medical conditions like, I don't know, diabetes or,
Yeah, actually, really interestingly, you're less likely to have an aneurysm if you have diabetes. So we don't have a, I think, great handle on why that is, but that is a negative risk factor. But it is associated with coronary artery disease. So if you've had a heart attack or you've had stents in your heart, and it is associated with peripheral arterial disease. So pain with walking due to blockages in the arteries.
And so you kind of went over the difference between an open surgery and an interventional. Is one better than the other, or is it just individual to the patient?
Yeah, so the younger you are, the more likely you are to benefit from the big open surgery. So I always say that there's a cost up front to the open surgery, and I think it pays off later on with durability. So if you're in your 50s, we probably would talk more about an open repair if you're otherwise healthy and have low risk factors. The older you are, the more benefit you have to not having a 2-week hospital stay up front, and having a short hospital stay and just moving on with your life. And so it really depends on everything that's going on with the patient and their age and their risk factors and what they need to be doing in their life, because 2 weeks it's a solid investment and up to a 3-month recovery time for this.
So if a person has an aortic aneurysm, should they also be screened for aneurysms elsewhere in their body?
Yeah, so not in particular. There's no particular guidelines for that. However, there is association between popliteal aneurysms, so behind your knee, and abdominal aortic aneurysms. So your vascular surgeon will do a physical exam and feel behind your knees. And if there's any concern there, we'll do screening ultrasound for popliteal artery aneurysms. But in general, when we look in the aneurysm, we look at all the arteries in the abdomen. And so if you get screening, if you're found to have an aneurysm, we do look at the iliac arteries and everything else in the abdomen. And then there's a question of whether or not we look at the backs of the knees based on the physical exam.
Are there any restrictions in terms of like an exercise program or anything straining that may cause a problem?
Yeah, I get that question a lot because you are told you have an aneurysm and you are told it could rupture, and then the question is, do you live your life or do you back off? And the research we've done on it doesn't give us a great answer, but we've never found an association between high exercise or sex or anything and aneurysm rupture. Now we know prolonged increases in blood pressure is more likely to expand and rupture. So we don't recommend extreme bodybuilding or really extreme activities. However, the little things, we're not seeing too much of an increased risk to show up in our studies. So I personally say you live your life. We know if we're not repairing it, we know you're at a low risk of it rupturing. So you just live your life and we will fix it when it gets to size.
And so high blood pressure is really the big issue with this, right? You want to get it under control.
So the high blood pressure is one issue. I would say always my number one issue is smoking. You have to remove that irritant from the walls of the artery, but high blood pressure and then getting the cholesterol into control.
All right, well, we've gone over our 30 minutes. So I want to thank you for being here today, and thank you for all of those who tuned in. This video will live on our Facebook page, and we will also post it later on our YouTube page. So thank you for tuning in. Our next Doc Talk will be the 26th with Dr. Kaufman talking about COVID, the latest updates on COVID. And then on February 17th, we will have interventional cardiologist Mark Villalon, who will be talking about Heart Health Month, sort of appropriate after this chat. Thank you all for tuning in.